Hi, everyone. Thank you, Angela. Thank you so much for having me. Like Angela said, my name is Anita Minh, and today I'm coming to you from the traditional, ancestral, and unceded territories of the Musqueam, Tsleil-Waututh, and the Squamish nations, on which I'm so fortunate to live and work. So I work as a postdoctoral researcher at UBC and the University of Washington. And recently, my research is focused broadly on employment and mental health. And in our seminar today, I'll be showing you results from a project that I worked on, which makes the case for the relevance of young people's depressive symptom trajectories in their transition into employment using data from Canada and the United States. So although adolescence precedes employment, it's an important formative period for the entire working life course. And this idea is premised around the concept of the sensitive period, a term that suggests that it's important to consider timing in questions of the effects of exposures on the development of health and illness. But why or what specifically do we mean by a sensitive period? So to start, I wanted to get a sense of your understanding of the concept. So I'd like to invite you to use the poll options to finish this sentence based on your own understanding of the term. Okay, thank you. I think we have quite a few answers already. So it looks like most people said all of the above. This was a bit of a trick question because there is no wrong answer. But all of these are different sort of ways of describing the sensitive period that emphasize different aspects of it. So for the research that I'm doing on adolescent mental health, so the research that I'm doing on adolescent mental health and the transition to the workforce, this sensitivity has been discussed in a few different ways. So first, there's the biological sensitivity, which was hinted at one of the answers. Beginning around puberty and ending in the mid-20s, neuroplasticity in the brain is heightened. And that means that in this period, there's a greater potential for stressful experiences to change the structure and the function of our brains. So studies in rats actually give us a good evidence of this. When you socially isolate adolescent rats, for example, turns out they develop irreversible cautious behaviors that can be traced to changes in their neurotransmission, whereas you don't see the same changes in adult rats. In the meanwhile, epidemiological evidence shows that 3/4 of all clinically diagnosed mental health disorders have their onset between adolescence and young adulthood. So the burden of disease is greater in this population. And importantly, severe disorders are usually preceded by less severe events. And they may not be brought to clinical attention, which creates a need for longitudinal assessments during this time. Finally, from a sociological perspective, adolescence is a period of social changes. So transitions like finishing education and transitioning into the labor market place young people into new roles and social environments that challenge their existing economic and psychosocial resources. One of the more concerning trends in adolescent mental health has been the rise in depression among young people observed since around 2010. And that's what you see for American adolescents in the panel on the left. And this trend has been observed across several indicators, from diagnosis to hospitalization due to self-harm, and also across various countries, including Canada. Of course, these concerns have been heightened by the COVID-19 pandemic. So on the right panel, you see the results of a meta-analysis of clinical level depressive symptoms in adolescents across the globe. And it suggests that the prevalence of mental health difficulties has likely doubled during the COVID-19 pandemic. If we conceptualize work as a life course construct, one that takes into account risks that precede the working years, this trend is concerning because it has potential implications for young people's social and economic futures. The transitions in mental health have potential for long-term impact on functioning, which in turn affects an individual's transition out of school and into the labor market. And studies show that adolescent depression is associated with a higher risk of high school dropout, early labor market disconnection, lower income, and welfare receipt. And this is because adolescent mental health affects attendance at school, classroom behavior, the likelihood of experiencing social exclusion, stigma, also substance use and distress. And then low education and early labor market disconnection in turn can have scarring effects throughout the working life. So the literature, we know from the literature that adolescent depression predicts later labor market outcomes. But at the time that we began the study, there were some gaps in the evidence of this relationship. First, the majority of studies tended to examine depression as a stagnant construct, often examining depression at only one time point. And this conflicts with evidence from studies in the field of developmental psychopathology, which suggested that actually people with depressive disorders spend the majority of their time without symptoms and with only intermittent periods of heightened symptomatic frequency. As such, there's a possible misclassification of young people with depression in existing studies. The analyses also focusing on assessing lifetime prevalence of depression also have only a limited ability to answer questions about when interventions are most effective for prevention. Second, there's this argument to be made that macro social institutions ultimately shape the life course experience of work. So this is a systems level perspective that was often overlooked in describing the effects of adolescent depression on their later employment outcomes. So for instance, this study by Bruce Bradbury and others is one of many that contrasts the US with Canada and other countries to show that differences in the healthcare system, child and family policy, and educational institutions ultimately drive country level differences in childhood academic achievement. And they do so by defining how financial, social, and health resources are distributed. Specifically, the authors argued that the US social safety net, by providing only meager resources compared to other countries during the early childhood period, has created a bottleneck for children's future opportunities, particularly for children with the fewest economic and psychosocial resources. So this was the rationale behind our study. We wanted to incorporate aspects of developmental change into the understanding of how adolescent depression influences education and employment, and to look for systems level differences represented by potential bottlenecks and opportunity. So we asked the question, what is the relationship between longitudinal patterns in adolescent depression and their labor market outcomes? And how does this relationship differ across similar but different educational and cultural contexts like the United States and Canada? To examine these questions, we used data from the National Longitudinal Survey of Children and Youth in Canada and the National Longitudinal Survey of Youth, specifically the child and young adult cohort in the United States. And using these data sets allowed for some overlap in the birth years and follow-up periods of the two cohorts. From these two data sets, we then created dynamic cohorts of young people who were followed from the ages 16 to 25. Because we were examining depressive symptom trajectories, we restricted the sample to those that had 3 or more time points of data so that we could add some reliability to the measurement of the trajectories themselves. So I'm going to present the results of these studies. So the study essentially proceeded in 2 parts. We first identified the depressive symptom trajectories. Then we looked at labor market outcomes at the endpoint of these trajectories. And today I'll describe 2 of these endpoints. The first is the young person's status in their school to work transition. And the second is full or part-time employment. We measured depressive symptoms using items from the Center for Epidemiologic Studies depression scale. And there were 5 items that were common across the 2 data sets. These 5 items map onto somatic as well as affective and cognitive symptoms for major depressive disorder. On the surveys, items were rated on a 4-point Likert type scale and then summed to a score out of 15, with higher scores indicating greater symptom frequency. In terms of labor market outcomes, first we conceptualized where young people were in terms of their success of their transition from school to work, with different states having different levels of advantage and disadvantage for future labor market prospects. So by the age of 25 or 26, some young people would be successfully working, but with no educational credentials, having made the transition out of school before attaining a degree. Others would have done so after secondary school or after post-secondary education. And then still others might have been unsuccessful in the labor market and ended up becoming disconnected from both school and work. And finally, there would be a group of young people who would have either continued with or returned to school. And then among those who are working, we examined their part or full-time work status. In order to characterize longitudinal patterns in young people's depressive symptoms, we use growth mixture modeling. So this technique essentially allowed us to identify multiple growth curves, or they could be called classes of change in depressive symptoms within the sample. It contrasts with conventional growth curve models because rather than estimating a single average curve, it estimates multiple within the sample. In addition, growth mixture modeling allowed us to estimate the variance of growth curve parameters within each class. We handled missing data for this part of the analyses using full information maximum likelihood. Part of the process of doing growth mixture modeling is deciding how many growth curves to select. And we did so based on both prior evidence and theory about the types of patterns that we expected, as well as model fit statistics. So in this case, we used the BIC and the significant likelihood ratio test. We also looked at average probabilities of class membership for each class. So higher probabilities in this case means a stronger class differentiation. And entropy, which is a measure, summary measure of differentiation between classes. And finally, we looked at the distribution of the sample across the classes to ensure that there wasn't a single class that was too small to be reliably identified. After creating the classes, we used multivariable regression to examine labor market outcomes associated with the trajectories. So these are the results of the growth mixture modeling in the American data. Again, to decide how many growth curves to select, we base our decisions on both prior evidence and theory, as well as these model fit statistics, which I presented here for you today. In this case, we used the BIC again. And then we also looked at average probabilities of class membership and entropy and the distribution of the sample across the classes. So you can see some of these statistics here. I thought it would be a fun exercise to go through the decision-making process together, just as an illustration of some of the challenges of doing growth mixture modeling, or more generally approaching a problem from a purely statistical lens or a data-driven lens as opposed to a theoretical one. So if you were to just look at these results, looking at the BIC, so generally you look for the BIC to decrease, indicating a better fit. Looking at the distribution, so trying to ensure there aren't too many groups that have a small percentage of participants in any one group. And then the entropy, so entropy meaning class differentiation, higher value is better for that. What would you decide? And I've also included along here the alpha, kind of give you a sense of how the BIC changes across different class solutions. So a steeper line meaning more information gained between moving between like 2 to 3 classes and 3 to 4 classes essentially. All right, we have 50% of people who participated. Any others? I know this is a kind of maybe unfair and hard exercise to ask you to do without prior knowledge of this method. Yeah, okay, great. So I'll just show the results actually. So essentially, we have a huge range of selections ranging from 3 to 6. The most popular is 4. Well, that's ultimately what we went with too, because we wanted to balance having, although the BIC continues to decrease past 4 classes, we wanted to balance having reliable trajectories as indicated by sort of these low group numbers. So we thought that using sort of as a rule of thumb, 5% would be a good way to assess that. But you could go, if you think there's more information with the 5 class, you could kind of go with that instead. Okay. So you can sort of see here how the individual trajectories are distributed across these trajectory groups. And you can see in our solution what the distribution across the 4 groups was. So the most populous group is the one in the bottom right corner, and that's characterized by generally stable symptoms, low symptoms over time. And then there are also smaller groups, and these represent the increasing and decreasing trajectories over the observation period, and that's between age 16 and 25, as well as a group that has a peak in the symptoms in the middle of the trajectory. And when we repeated the procedure in the Canadian data, we found qualitatively similar trajectories, which we were pleasantly surprised by. And it's interesting to note, actually, that when we compare the trajectories to others in the literature, they look similar as well. So these studies, these are the findings from a study using the Avon longitudinal study of parents and children in the UK, also called ALSPAC. And they also look at depressive symptoms on the y-axis using a different measure, the short mood and feelings questionnaire, which is a 13-item questionnaire as opposed to our 5-item one. And they assess between ages 11 to 25, and they also show similar trajectories. We didn't find this one, the childhood persistent trajectory, likely because we had fewer items to work off of than they did. When we looked across the endpoint of these trajectories for young people's education and employment outcomes, we also found some evidence that these trajectories differentially predicted young people's outcomes in the school to work transition. So what you're looking at here is the predicted probability of each education and employment outcome in the school to work transition. And this is adjusted for sex, race, and a number of other socioeconomic variables. The Canadian results are in red and the American results are in blue. So I think the differences by trajectory are the clearest if we focus on the probability of what is arguably the most favorable outcome, and that's working with a post-secondary degree. And we see that this outcome is least likely for those who have a trajectory of increasing symptoms. But even amongst those with decreasing symptoms, there is a lower likelihood of working with a post-secondary degree compared with those with low stable symptoms. And these results suggest not only that depressive symptoms present potential challenges to the transition from school to work, but also that the timing and change to these symptoms might make a difference. And these results also support the idea of adolescence as a sensitive period in the working life course, since even decreasing symptoms mean a lower likelihood of a favorable outcome in the transition from school to work. I will say that these findings are consistent with other recent studies, both amongst those who use these trajectory-based approaches to examine the question of timing and mental health problems, as well as those that don't use trajectory-based approaches. So for example, the UK-based study that I just showed you earlier, they similarly found that recent symptoms appear to have the strongest relationship with lower educational attainment and labor market disconnection, but that even those who showed only child-limited symptoms were at greater risk of these outcomes. And similarly, a study looking at the timing and duration of mental health problems and their association with labor market participation in the Netherlands found that both early onset of symptoms, so that's before age 16, as well as late onset of symptoms, so after age 16, were associated with elevated risk of not working at age 26. In our study, though, because we looked at both Canada and the United States, we're able to observe differences between countries that hint at a system level difference. So going back to that figure, for example, when we zoom out and we look at the overall distribution of outcomes in Canada, we see that young people are most likely to be in school or working with a post-secondary degree. And I kind of highlighted this in the red boxes here. This was true for all trajectory types. But in contrast, Americans were more likely to be in school or working with a high school degree. And there are a lot of potential reasons for this difference, institutional differences that determine the funding of primary and secondary education, accessibility to tertiary education. Those are possible reasons for the difference. These systems level differences may be important considering that in both countries, lower educated workers are more likely to work in precarious conditions over their working life course. and less likely to have advancement opportunities compared to more educated workers. Finally, there are some differences in the likelihood of part-time work by country. So you're looking here at the prevalence ratio for part-time work compared to full-time work by trajectory and by country. And in Canada, trajectory type was not found to be related to the risk of part-time work, but in the US, both increasing and decreasing symptoms are related to working part-time. And part-time work might not be undesirable for people who have major depressive disorder, some of whom might desire more flexible working arrangements. However, there might be long-term adverse implications for working part-time for employment stability, occupational advancement, income, and wealth. So the predominant policy response to support labor market integration in the US and Canada has been to prevent high school dropout and or re-engage young people in education. That makes sense because education is an extremely strong predictor of adult labor market outcomes. However, when it comes to the potential for these initiatives to support adolescents who face mental health challenges, these policy efforts haven't been matched by a comparable level of evidence. Until only recently, it was somewhat unclear the extent to which intervening education variables like high school completion drives the risk of future labor market disconnection for adolescents with mental health problems. But what we do know from the literature is that fewer years of education and lower credentials explain about 11 to 32% of the effect of childhood hospitalization on earnings, years employed, and the receipt of income transfer in early adulthood. And so we undertook a study to examine this question about the role of high school graduation in the path from adolescent internalizing problems. So those include depressive and anxiety symptoms, as well as their externalizing problems, and those include behavioral and attention problems on their labor market disconnection at age 25 or 26. And essentially the goal of this analysis was to understand the extent to which the total effect that mental health problems have on labor market disconnection could be separated into the effect that it had through its influence on high school completion, which we call the indirect effect, and shown in this schematic with a dotted arrow, and the extent to which it was related to other pathways, which we call the direct effect, shown in the schematic with the bolded solid arrow. And we're surprised to see that the indirect effect, though it was significant, was only a small part of the relationship between adolescent mental health and labor market disconnection. So what you're looking at are the estimates of these direct and indirect effects on labor market disconnection as expressed as the percent probability of labor market disconnection. And we looked at this in 2 American cohorts born in different decades. The indirect effect, which I've highlighted, seems to account for only between 4 and 7% of the total effect, showing that most of the effect of adolescent mental health problems on NEET was not explained by high school non-completion. Well, in this study, we didn't investigate alternative pathways to NEET or labor market disconnection, but other research points to potential mediators. And so, potential mediators include persistent mental health problems between adolescence and young adulthood, and they may present behavioral and social challenges that affect a young person's ability to apply for and maintain post-secondary education and work, as well a shortage of integrated health and social services, inadequate connections to early employment supports, and a lack of sustained support over their careers might also put those who have mental health problems in adolescence at a higher risk of disconnection in young adulthood. So of course, there are some limitations to this work. First, there was possible selection bias due to differential attrition and non-response. Second, there are a number of sources of potential measurement bias due to the self-reported nature of the data. And we also had limited indicators for depressive symptoms. And the use of we only use a single endpoint to represent the school to work transition. So related to that, the temporal ordering of mental health and events in the school to work transition wasn't established. So we should be careful about inferring the direction of causality in these studies. And then the last study I just showed you, we might also be missing some key education-based mechanisms. So should be careful about concluding about the effectiveness of education-based interventions. Finally, we should be careful to interpret the cross-national findings as indicative of the causal effect of institutional differences between countries, since there are differences between the two cohorts, not only with regards to their sampling strategies, but also unobserved cultural and historical differences that might account for these results. This evidence does, however, support a number of conclusions. So I was hoping we could do a quick take-home poll about what you took away from this presentation. So what do you think was, which of these was supported by the evidence that you saw? Okay, great. Thank you, everyone. I'm happy to see that a lot of people felt like all of the above were supported. These are the take-home messages that I would like to impart from this presentation: that adolescence is a sensitive period for the work and life course, that depression in adolescent and young adulthood is associated with challenges in the transition from school to work that impact future labor market opportunities. There's some evidence that patterns of timing and change in depressive symptoms have implications for the transition from school to work. As well, systems level differences might ultimately shape opportunities for young people in the transition from school to work. So thank you all so much for coming to the session and listening today. I'd like to thank my co-authors on this study, who are my supervisors on my doctoral work. I couldn't have done this without their support. And of course, I'd like to acknowledge the funding that I received to be able to do this work. These findings were published in 2 journal articles, so please have a look if you're interested.